Okay, it's 10. Are you with me, everyone? Can you see the PowerPoint? I just finished the DO class, so I apologize, but we are on time. It takes time to switch, huh? And are you happy with the remote class? class, though. Okay, so I'm sorry, I have a dry throat, and we'll see if I can help you today. How do I help you today with? So you know that we have, I hope you have the right topics, right? I always ask in the class. So you have inborn errors and amino acid metabolism today, but I'm going to finish the last two questions of urea cycle. So let's see, let me get to where we were last. Did we talk about urea cycle? Yes, but we didn't do the last two questions. So let's first quickly see what we had in urea cycle. Okay, so is it both cytosolic? Are you seeing my slide now, urea cycle? So just let's quickly review urea cycle. We had last two questions. Let's do them. Then we'll start what we have today. Today we have amino acid metabolism and inborn errors, both cytosolic and mitochondrial, right? Cyte is where? Liver or kidney? Urea cycle? Liver or kidney? You can put in the chats. That's okay. Good. Yes, liver, absolutely. Liver is the side. That's why if BUN is low, that means there is something wrong with the liver. Is CPS1 rate limiting enzyme, not CPS2? What is CPS2 for? Which pathway? CPS2? CPS2 is for? CPS1 is pyrimidine synthesis, absolutely. Is NAG doesn't mean nagging, but it's an activator of CPS1 or CPS2, NAG. NAG is CPS1 or CPS1, not CPS2. So we did urea cycle synthesis in the liver. We know that it's excreted through kidney in the urine. We did all the 5 steps, right? But we want to distinguish 1 from 2. I told you, do that. Draw it separately. The problem with 1 and 2 is, are all high. Is ammonia high in 1 as well as 2? Let's do that. Is ammonia high in 1 as well as 2? Are you seeing my slides first? For urea cycle, everyone? Is glutamine high in 1 as well as 2? Is BUN low in 1 as well as 2? So then we got to differentiate. Yes, when BUN is low, pathology is liver. More common liver pathology, but we also discuss urea cycle enzyme deficiency. So should you distinguish 1 from 2? Yes, because both of them present as high ammonia, high glutamine, and low BUN. So that's not enough. So let's see what leads to hyperammonemia. Okay, is hyperammonemia, is ammonia detoxified in the liver? Is ammonia detoxified in the liver to form what? Urea. So if ammonia is high, when ammonia is high, that is arginine, when arginine activity is increased, will ammonia be high? Is it true? No. Always rule out the answer. Pepsin. Has pepsin anything to do with ammonia? Where was pepsin? Gastric or intestinal? Pepsin, gastric or intestinal? Pepsin, gastric. Is urea made in the intestine? Is urea made in the intestine? No, C is wrong. Okay, this could be right. Why there's hyperammonemia, that some cells are unable to synthesize urea. That could be right? What about BUN? Is it an indicator of liver damage? High BUN? When BUN is high? No, what is it an indicator of? Kidney damage. So what is your right answer? D. Please rule out your answers. Now, secondly, I told you distinguish 1 versus 2. So 1 or 2, where carbamoyl phosphate would be low? 1 or 2, where would carbamoyl phosphate be low? 1. Please know that. In carbamoyl phosphate would be high in 2. So which is CPS1 defect, 1 or 2? Which is CPS1 defect, 1 or 2? 1. So do you understand? Enzyme is different, step is different. What is accumulating and depleting is different. So absolutely, carbamoyl phosphate will be low in one and high in two. But what else will accumulate in two which you will not see in one? Apart from carbamoyl phosphate, what else will be high in two and you will not see it in one? You clearly know that. Orotic acid, very good. And can you add one more? No, BUN will be low. Uracil, very good. Uracil, that is the right answer. You know why? You know why? Because carbamoyl phosphate, you see, right? Accumulating here will go in cytosol in pyrimidine synthesis. It goes into pyrimidine synthesis. And that's why also along with carbamoyl phosphate in two, what will be high? Orotic and uracil. So it is very clear when orotic acid is high. First of all, whenever they say orotic acid, you will relate it to pyrimidine pathway. Only pathway where orotic acid is discussed is pyrimidine. We will do that. Secondly, if orotic acid is high, will you pick CPS1 deficiency? If orotic acid is high, do you want to pick CPS1 deficiency? So please, there is a big no and there's a big yes. So always draw these as I have told. I don't give you line diagram because I love them. So they can help you understand that there are different steps, different vitamins, different accumulation and different depletion. Now look at this. They have an inherited defect in OTC. So OTC, they are talking about one or two, hyperammonemia one or two, OTC. One or two? Two. Okay. So will tyrosine be high in them? Tyrosine has anything to do with hyperammonemia too? Wrong. Arginine, would it be high in these patients? Arginine. Arginine. Would it be high or low? Arginine. They're asking high. Arginine would be high. Low. Citrulline. High or low? Low, absolutely. Urea. Urea. High or low? Low. So that's why what is your right answer? So everything is not the substrate and the product. So do you understand that ammonia will accumulate in hyperammonemia type 2? Absolutely, right? Will glutamine also be high? Yes. So see, you're ruling out the answer. Does that make sense? So this is all you got to do. Draw these steps separately and see what is accumulating, what is depleting. Please do not mess up. Oh, sorry. So now you please pick A as the right answer. And this is your attendance for the last session. And you will get two attendance because Dr. Chalagundula missed your attendance. So these are 2 points. So please do that for me. Please. You will pick A as the answer. Is
Dr.
everybody
Bob,
able to do that?
how do we
Yes?
enter the answer? Where do we enter it?
The poll is
Oh,
open. I
Poland.
see
Oh,
students
Poland.
clicking.
I
You
didn't
just
know.
got to do as you do in the
Can I
class.
see the
I
thing?
see students clicking. Yeah.
Can I see the thing to scan it? I don't have it. Can I see the scan
Sorry?
thing?
Oh, scan. Okay. Look at this. This is good. This is good now.
Mm,
Yeah, I don't want you to lose your grades, but let's not waste 5 minutes on it too. All right.
thank
Everybody
you.
good? Did you scan it now?
Yes.
Okay, good. Tell me when you are done so we can
Uh,
do the next session.
what was the answer? No.
Great. So you got 2 points here, please. Attendance was not taken. Everybody is good? Okay, are you done? Not yet. Okay, no worries. If you're having issues, please email me. Let's not waste time. That's okay. Okay. If you have issues, just email me. Don't worry. Everybody, don't worry. If you have issues, that's okay. Let's do the next session. That's okay. Oh my God, am I stuck now? Okay, give me a minute. I got to log out. Okay, give me a minute. Mhm. Guys, give me a second. Wow. God, I'm having technical difficulties. Just give me a minute. Are you with me? I'm not able to log out. Are you seeing my screen, everyone? Or am I frozen?
We can see it now, ma'am. It's all G.
I'm sorry, but I'm having glitches here. I can't escape out. I will try. Give me a minute, please. Well, we would have some glitches because this is our first time with the hole everywhere here. Give me a minute, please. I'm sorry. Hmm, okay, see something here. Guys, I'm stuck here. I'm just give me a few minutes. Okay, great. Okay, great. That was a lot of time, believe me. We are trying. This is our first time. Okay, I'm good now. Let's see, we can start with the next session, which is amino acids. And okay, now you seeing the next session now. Everybody, I'm sorry, this is our first time, so there would be some glitches, but we are good now. Are you good now, everybody? Is it the next session? Are you seeing it? Great. Everybody, is it week 18 now?
Yes, ma'am.
Great. So let's see what we have today. We have amino acid metabolism and inborn errors. Great. Stick to your learning objectives. Have we already done amino group disposal? Absolutely. This is not our section today. Our section today is carbon skeleton. I don't want you to memorize any reaction, except know that if carbon skeleton converges into TCA intermediate, energy. TCA other than acetyl-CoA, glucose. Acetyl-CoA, ketone. What about pyruvate? If amino acid carbon skeleton converges into pyruvate, what will they give you? Anyone? Glucose. Then memorize the amino acids. Which amino acid is glucogenic? Alanine or leucine and lysine? Which amino acid is glucogenic? Alanine, alanine. Which amino acids are ketogenic? Can you give names? Amino, no, purely ketogenic, leucine, sorry. Purely ketogenic, leucine and lysine. Glucogenic, here, you see my cursor? Alanine. So keep them separate. Just know these four fate and know the amino acids which are ketogenic versus glucogenic. Don't memorize these amino acid and waste your time or reaction. I told you sorry, if they converge into TCA cycle intermediate, energy. TCA cycle other than acetyl-CoA, glucose. Pyruvate, glucose. What about acetyl-CoA? Amino acid converging into acetyl-CoA will give you glucose or ketone bodies? Ketone bodies. So understand what is glucogenic, what is ketogenic. This is different classification. And we are not doing amino disposal, though this is a good summary of amino disposal. We are doing carbon skeleton. To understand carbon skeleton, is alanine glucogenic? Yes. Is alanine glucogenic? How have we learned? Is it a principal storage amino acid in muscle? You cannot flip-flop that. Nitrogen flows from where? Muscle to liver, and carbon flows back from liver to muscle. Is this glucose-alanine cycle? Is it part of gluconeogenesis? It is active all the time, but turns on big time in low insulin state. So understand that. This carbon skeleton, what's amino group is removed, carbon skeleton can converge anywhere to be useful to our body. It's not a waste. So I told you fate. So you have learned carbon skeleton of alanine being glucogenic by this step, right? Did we introduce the step? Yes. So just two. Now, these last two reactions are coming back in renal. So is alanine released from skeletal muscle? Is alanine released from skeletal muscles? Yes or no? Is it glucogenic? Yes. Have you done this step also? Propenyl-CoA, succinyl-CoA pathway. Have you done this step earlier and it's coming back in amino acids? Yes. Please do these two steps. Now let's do the question. So which amino acid can be metabolized to be, if the amino acid converges into pyruvate, what will you label that as? Though you know that classification, essential, non-essential, glucogenic, ketogenic. So let's first rule out, don't memorize answer. Is this, the statement is saying amino acid, question stem is saying, amino acid converges into pyruvate, what will you call it? Will you call it essential? Has essential anything to do with glucogenic, ketogenic? No, essential means cannot be synthesized in your body, supply it in the diet. Anything that converges into pyruvate, is it ketogenic? B? No. C could be right. Anything converging into pyruvate is glucogenic. Does it look right? Yes. Till rule out the other answers. Aromatic amino acid. Name the aromatic amino acid. Name the three aromatic amino acids. Phenylalanine, tyrosine, and tryptophan. Are they polar or non-polar? Phenylalanine, tryptophan. Let's look at phenylalanine, tryptophan. Non-polar. So know that polar, non-polar too. Non-essential, no, it's nothing to do with glucogenic. Non-essential are not synthesized in your body. So your answer is what? C. So you know how to rule out the answer. Keep these classifications different. Essential, non-essential is on synthesis. Glucogenic, ketogenic is on what they are converging into. They are different classification. Aromatic are phenylalanine, tyrosine, tryptophan. They are neutral amino acids. They are non-polar. So, should you know the classification of essential, non-essential? Apart from them, conditionally essential. They are also very important. Conditionally essential means which become essential when there are specific conditions. For example, there is a urea cycle enzyme deficiency disorder, and they are asking what should be supplemented in a diet of a growing child. It's a child, right? So now you got to understand that means this, they are asking about some amino acid which is synthesized by urea. So let's rule out the answer. Is glycine synthesized by urea cycle? No. So where have you seen glycine? Now don't stop there. If you want to get good grade, I told you make the list amino acid what they form. So what does glycine form? Is it part of collagen? Heme? Creatine? These are very important. Yes. Is glycine forming nitric oxide? So glycine is part of heme, collagen, uh, um, purine ring, creatine, conjugation of bile acid, glutathione. Why not? Very good. You know the lesser ones too. So you complete the list. But does glycine form nitric oxide? No. So don't keep it there in that list. So your list for glycine would be collagen, heme, purine, creatine, glutathione, conjugation of bile acid. So don't flip-flop the list. So do that. Alanine. Is alanine formed by urea cycle? No. Well, aspartate, is it formed by urea cycle? Is it formed or is enters urea cycle? It enters urea cycle. Glutamine, where have you learned glutamine? Is it formed in urea cycle? No. No, glutamine is not. But what is it important for? What is it a major form? What is it? in your body? Glutamine. It is a major transport form. Is glutamine the only transport form? What's the other one? Is glutamine only transport form? What is your alanine? So, right? So, arginine. Is arginine synthesized by urea cycle? Yes. So, this could be the right answer. This is known as conditionally essential. Arginine is required during growth, reproduction, pregnancy, and especially when you have a urea cycle enzyme defect. So, do you understand these classification? Essential, non-essential, conditionally essential? Do them, especially conditionally essential. Here, don't waste your time, except start making amino acid in list. So, tryptophan, tell me, tryptophan forms melatonin. What else? What else? Tryptophan forms niacin and serotonin. Now, don't stop there. Tryptophan forms niacin. Where have you learned that? Which disorder? Do you relate that? So, first normal, then abnormal. Tryptophan forms niacin, melatonin, and serotonin. Now, where do you see niacin, tryptophan, niacin? Heart nerves disease. Now, where do you see serotonin? Two places. Serotonin you see with carcinoid tumor. Serotonin you will see with depression. Yes, you want to increase serotonin availability in depression. So how can you increase serotonin availability? Either increase synthesis of serotonin, or yes, block MAO, prevents its degradation. But then you should know normal. Who synthesizes serotonin? Who synthesizes serotonin? Who synthesizes serotonin? Tryptophan. Who degrades serotonin? Who degrades serotonin? MAO. So you should first know normal. That's why MAO inhibitors will be beneficial in depression. So then do clinical. But see, I went from normal to abnormal. Does that make sense? Not jumping to depression first. What does tryptophan forms? Serotonin. How is serotonin degraded? MAO. Then MAO inhibitors, depression. So you got to connect. So let's look at this. We talked about carcinoid tumor, high serotonin and high serotonin degradation product 5-HIA, depression, increased serotonin availability. So then you go clinically. Does that make sense? Right? Let's do this question. Okay, let's do this. So you're talking about MAO inhibitors and depression. Has it anything to do with synthesis? So wherever there is synthesis, A and E, you will not pick it, right? MAO is to prevent degradation, not to do with permeability. You could be lost between C and D, because when they say MAO, which is inhibitors, which is preventing degradation and depression, you're thinking of serotonin. But is it C or D? Do you want to pick C or D? MAO inhibitors prevent degradation or affect synthesis? C. Does that make sense? Those selective serotonin reuptake inhibitors are popular antidepressant, but both of them aim at only one thing: increase serotonin availability. So your right answer should be C, not D. Does that make sense? Inborn errors. You should do all inborn errors of metabolism, please. So let's not get lost. Did we do digestion and absorption? Did we talk about amino acid pool? Did we remove the amino group with transamination, deamination, transport form, and urea? For carbon skeleton, what did I tell you? Just know why is this fate and what does it give you. For this list, I told you make a list of amino acid and what specialized product they form. Don't flip-flop them, right? Put them in the right place. What section are we doing now? Inborn errors of metabolism. But common mistakes students make is each amino acid has two roles in your body. Keep them separate. They form specialized products, which is the last one, and they are also metabolized in your body. When they cannot be metabolized, then comes inborn errors of metabolism. Does that make sense? But they are two separate things. So let's do all inborn errors of metabolism. Please, please, and please do all of them. Do which enzyme deficiency? Vitamin. Please take your daily vitamins and bring them on the exam too. Oh, it's going on its own. There's a timer. Sorry. So do which enzyme, which step? I'll tell you how to do it. Do them all, right? Did we do cystinuria versus Hartnupp's disease? Did we do cystinuria versus Hartnupp's disease? Absolutely. Great. Do that. Now let's see what are these inborn errors of metabolism. First of all, phenylalanine levels are high in both. So you should not jump to PKU when you see high phenylalanine levels. It could be due to enzyme deficiency or cofactor defect. That is why first know normal. What you got to do when you go back home is you know the step, normal step, enzyme required, and vitamin required. Now, students are confused with the word coenzyme cofactor. They are interchangeably used, but they help the enzyme. Every step is catalyzed by the enzyme, but helped by coenzyme or cofactor. Coenzymes are vitamins and organic. Cofactors are inorganic. But what you want to understand in enzyme deficiency is inborn errors disorder is enzyme deficiencies are severe. Cofactor defects or coenzyme defects are mild, but they both can present with one common presentation. For example, here enzyme deficiency versus cofactor defect, what is common to them? High levels of phenylalanine. But you got to differentiate. If it's enzyme defect, it's classic and severe. If it's cofactor defect, it's non-classic and mild. Does that make sense? Also, presentation is different. I will go back to the slide. I will go to that slide and understand that. Treatment. What will you do for treatment in both? Restrict phenylalanine naturally, right? Because it's high. Will you restrict phenylalanine? Yes. But what is the difference in presentation? First, let's go. Common, they all have phenylalanine levels high. Common treatment, you got to restrict phenylalanine, right? But let's see now what's the difference. First, this is classic, this is non-classic, this is severe, this is mild. Are you clear with both of them, right? Now let's go further. Now also common presentation. When you say phenylalanine levels, they affect which system? CNS, joints, or liver? What is the damage they cause most? High levels of phenylalanine to your CNS symptoms. So you got to have a CNS history. If you see a history of arthritis, where will you go? I will tell you. But if you see a history of arthritis, don't go to PKU or cofactor defect, tetrahydrobiopterin. You got to see a history of CNS changes. So please also be vigilant. What is my presentation? So you know where you have to go. Enzyme, please stay around the test, around the step. The substrate accumulate, product is depleted. Also, substrate accumulation follows alternate pathway that becomes major. So what is this alanine to pyruvate? Have you learned anywhere alanine pyruvate? What was that? Alanine to pyruvate. Was there some reaction? Was it deamination or transamination? Alanine pyruvate. Deamination or transamination? Sorry, transamination. So these transamination products are responsible for musty or mousy odor in classic PKU, which is enzyme defect, not cofactor defect. Classic PKU, classic is enzyme, not cofactor. And the keto acids are responsible for musty or mousy odor, not phenylalanine, please. Phenylalanine causes CNS changes, right? And also, if you didn't have the list, do you think you would understand that PKU patient may also present as what? What can PKU patient may also present as, or may also have apart from not albinism? No. Albinism is total absence of melanin in the melanosome. It's a tyrosinase defect. PKU patients never present with albinism. Hypopigmentation, fair skin. I would say hypopigmentation. Fair skin could be also a relatively right answer. Albinism, not a right answer. It is hypopigmentation, right? But unless you know the list. So complete the list. What does tyrosine forms? Epinephrine, norepinephrine, dopamine, and melanin. You got to make the list of the amino acid and their specialized products, and it got to be right and complete. Does that make sense? Right? And if you didn't know this, you will not understand PKU patient with present with hypopigmentation, not albinism. Albinism is different. So also, please, it's important for you to connect. When I say albinism, is it phenylalanine defect or tyrosine defect? So keep them separate. Phenylalanine tyrosine stops there. Tyrosine is different now. Don't connect. So when I say albinism, is it phenylalanine defect or tyrosine defect? Which amino acid defect is albinism? Phenylalanine or tyrosine? Tyrosine. Now complete the list. Tyrosine defect is albinism. What else? What else? What else is tyrosine defect? Albinism? Albinism? No, give me the inborn errors. What are tyrosine defect? Albinism? What else? Alkaptonuria? What else? Tyrosine. Be very tyrosinemia type 1. So do tyrosinemia type 1, albinism, and alkaptonuria. These are tyrosine defect. PKU is not tyrosine defect. It is phenylalanine defect, right? But what is the difference? Classic is enzyme, non-classic is cofactor. What is the difference in presentation? In non-classic, if you restrict phenylalanine and send the patient back home without doing anything else, they will come back with neurological signs and symptoms. You know why? Because tetrahydrobiopterin is not just used by phenylalanine hydroxylase, it's also used by tyrosine hydroxylase and tryptophan hydroxylase. So in cofactor defect, you got to supplement other neurotransmitters apart from restricting phenylalanine. If you don't do that, these patients will come back with neurological signs and symptoms. But cofactor defect is mild. They do not present as musty odor, a lot of CNS changes. That is enzyme deficiency, classic. And look at this. This is the major pathway. Look at in PKU patient. Everything down the pathway becomes light. An alternate pathway becomes major, which is responsible for musty or mousy odor. This is a very excellent slide. And look at this. There are two pathways for each amino acid. Either they form specialized products or they are metabolized. Two are separate, right? I have done it with my line diagrams. Let's do this question now. You see developmental changes. That means there are CNS changes. There is delayed development. Are you thinking PKU? Why should you not? Absolutely. And they're also saying musty and a mousy odor. So first of all, are you thinking phenylalanine levels are high in this patient? Should phenylalanine levels be high in these patients? Do you think? Yes, but now you have to distinguish, is it classic or non-classic? Is it non-classic, which is is this non-classic history? Is this a non-classic history or a classic history? This is a history of classic PKU or non-classic PKU? Is it non-classic history? This history, question stem. No, it is classic. So A is wrong, right? Succinyl acetone, it is seen with phenylalanine defect or tyrosine defect. Whereas Dr. Panini taught you succinyl acetone accumulation. Phenylalanine or tyrosine? Phenylalanine or tyrosine? Tyrosine, wrong. Acetoacetate, tyrosine. Homogenesic acid, where does it accumulate? Phenylalanine or tyrosine defect? Phenylalanine or tyrosine? Which tyrosine defect? Complete your, if you want to get good grades. Which tyrosine defect will you say see homogenesic alkaptonuria? Not in albinism, not in tyrosinemia type 1. So will you see E here? Should E be right for musty or mousy odor? The corresponding keto acid of phenylalanine? Are they responsible for musty and mousy odor? Yes. So that would be your right answer. Rule out your answer. Complete where have you seen them other places, right? Also, I'm going to do my A. So A is known as very good. Why not? So A should be non-classic history. Non-classic history is mild. It's not associated with CNS changes. It's not associated with musty and mousy odor. Also, in a non-classic history, they should say, okay, we found the cofactor defect, we supplemented the neurotransmitters, and the patient became better. Then it will be a non-classic history. Because tetrahydrobiopterin is not just used by phenylalanine hydroxylase, it's also used by tyrosine hydroxylase to form catecholamines and tryptophan hydroxylase to form serotonin. So that's why it's not this history, right? Similarly here, you should separate these two. There are two different metabolism. Each amino acid forms this specialized product, make that list completed, and they are also metabolized. Secondly, where is alkaptonuria? This one is alkaptonuria. This one is alkaptonuria, or this one? First or second? Which is alkaptonuria? First or second? First or second? First one is alkaptonuria. Second one is tyrosinemia type 1. You got to understand where the step is. So tyrosinemia 1 or alkaptonuria. Where will fumaryl acetoacetate accumulate? Tyrosinemia 1 or alkaptonuria. Where will fumaryl acetoacetate accumulate? Alkaptonuria or tyrosinemia type 1. So understand the step, substrate accumulate, product is depleted, right? Also understand tyrosine is glucogenic, ketogenic, or both. If I say tyrosine forms fumarate and acetoacetate, both. So see, don't memorize the reactions. Okay, do the clinical condition. Also, if it is given tyrosine forms fumarate and acetoacetate, know the concept which I have given in the line diagram. Yes, it's both glucogenic as well as ketogenic. So not in alkaptonuria and tyrosinemia type 1, fumarate acetoacetate will accumulate. Yes, what's your question if it's quick?
Just a quick question. So, the DOPA in the first mechanism, like, is that for eldo? Is that stand for
Yes,
dopaquin?
yes, the DOPA is a precursor for dopamine and
Okay.
norepinephrine and epinephrine, the catecholamines. That is given in non-classic patients too. It's a precursor,
It
yes.
wouldn't. It wouldn't be. I kept thinking that it was dopaquinone.
No,
Dopaquinone because on the.
DOPA normally is a precursor in the body. So let's not confuse the normal intermediate with the drug. We'll talk about that later. I'm talking
Okay.
about the normal intermediate. It's a normal intermediate in your body which forms the other catecholamines, right?
Gotcha. Thank you very much, ma'am.
Okay. Yes, this is not the drug. This is not synthetic. This is not, we are talking about the normal intermediate and product in your body, which is dopa and is a precursor of other catecholamines in your body, right? So not in alkaptonuria, but tyrosinemia type 1, you will see fumaryl acetoacetate accumulating. That is very important because you are to differentiate, right? Secondly, arthritis history. Will you pick PKU or alkaptonuria? Arthritis. Arthritis affecting joints, alkaptonuria, because alkaptonuria, you have homogentisic acid, which causes alkaptone bodies. It gets deposited in the skin, sclera, connective tissue. It disrupts the joints. So see, alkaptonuria is higher up. Tyrosinemia type 1 is lower, as you see my cursor. Alkaptonuria is here, right? Tyrosinemia type 1 is here. So steps are different. So alkaptonuria here, tyrosinemia type 1 here. So don't mix and mess them up. Don't flip flop them. Don't flip flop the substrate and the intermediate. Secondly, tell me alkaptonuria. Do you see my cursor here? Alkaptonuria or tyrosinemia type 1? Where will succinyl acetone accumulate? Alkaptonuria or tyrosinemia 1? Where will succinyl acetone accumulate? Tyrosinemia type 1. This is hepatotoxic. That's where Dr. Panini has mentioned. And you use this drug to reduce succinyl acetone accumulation, right? So understand where it will accumulate. In alkaptonuria, you will not see succinyl acetone accumulation. In tyrosinemia type 1, yes, you will see. So that is also important for you to understand where this intermediate is accumulating in which step, right? Now look at this stiffening of joints. You're not thinking of PKU. Then brownish discoloration, darkening of cartilage, sclera, skin. So is it a tyrosine defect? Can this be a tyrosine defect? Joints affected and darkening of skin, sclera, black urine. Can it be tyrosine defect? Are you thinking tyrosine? Yes. But which one? Albinism or alkaptonuria? Albinism or alkaptonuria? Alkaptonuria, homocysteine. What would you see in homocysteine? High homocysteine affects Small and medium sized vessel. You will see a history of myocardial infarction. Do you see myocardial infarction here? Do you see myocardial infarction here in this history? No. So this is not homocysteine. What was isoleucine? Leucine, isoleucine, valine. What were they? Leucine, isoleucine, valine. What were they? These three. Branch chain, which was which disorder? Maple syrup urine disease. Is there any maple syrup urine history here? Is there maple? No, it's not isoleucine. Phenylalanine, is there any CNS changes here? Are there CNS changes, musty odor? No, so it's not phenylalanine. Histidine is metabolized by folic acid. Please bring in your vitamins. Absolutely, absolutely important. Take your daily vitamins and bring them on the test. Histidine is metabolized by folic acid and does not present like this. So that is why your answer should be what? Tyrosine. Please rule out your answer. Histories are very significant. You should not be confused. And if you master them, does that make sense? Right? Then do folic acid. Yes, maple syrup from branch chain amino acid. Right. Well, however, you can understand that. But folic acid and B12 deficiency present as macrocytic megaloblastic anemia. They are one carbon carrier. I don't want you to memorize the form, but Dr. Panini has mentioned these two forms, methyl and adenosine. Cobalamin is B12, folic acid, tetrahydro folate is folic acid. But I'll still tell you, though I don't want you to memorize these forms. Methyl is for methionine synthesis. Formyl is for purine synthesis. Methylene is for thymidine synthesis. Methyl here is for methionine synthesis. Now tell me which one is for this one. Adenosyl cobalamin is for what synthesis? I'm not asking metabolism. What synthesis do you see adenosyl cobalamin? What synthesis do you see adenosyl cobalamin? No, MMA is not synthesized by it. Synthesis. So you're going wrong. You have to be specific. Sam is not here. Sam doesn't work here. Sam is not your next door neighbor and does not work here. Tyrosine, no. Who will give me the right answer? Adenosyl cobalamin. Go back. Go to the slide. Succinyl CoA. It metabolize MMA, but it's used in the synthesis of succinyl CoA. It can cause, no, it can cause MMA when it's low or defective. But I'm not, so you have to distinguish normal from abnormal. I'm specifically asking you. Adenosyl cobalamin is used for the synthesis of. You're not going MMA, that's pathological. It's not to form MMA, it is methylmalonic acid. It is to form succinyl CoA. Very good. That's the right answer. So this is how specific you got to be with the step, please. Because substrate accumulates and product is low. If you don't know that, you will flip-flop that. So adenosyl cobalamin is used for succinyl CoA synthesis in your body. Okay, does that make sense? Sam, not your next door neighbor for epinephrine nor epinephrine synthesis. Now tell me, this is what I was asking you. Adenosyl cobalamin, look at my cursor. It is used for succinyl CoA synthesis, not methylmalonyl CoA. It's used for succinyl CoA synthesis. It is metabolizing methylmalonyl CoA. Now come to the disorder. First, write down the step. Right enzyme, right vitamin, normal. Then do the defect. Now tell me, biotin deficiency or B12 deficiency, where will you see low MMA? Low methylmalonyl CoA, sorry. Biotin deficiency or B12 deficiency, where will you see low methylmalonyl CoA? Biotin deficiency. So then you do the step, right? Does that make sense? Also, is B12 only used to form succinyl CoA? B12 is also used for what? Is B12 used only to form succinyl CoA in your body? Methionine also. You get my point? That's why Dr. Panini has clearly distinguished MMA1 from MMA2. MMA is only adenosyl defect. So what would be low? What would accumulate in an MMA1? It's only adenosyl defect. It's only adenosyl cobalamin, not methyl cobalamin defect. So if it's only adenosyl cobalamin, what will accumulate in MMA1? What will accumulate in MMA1 because it's only adenosyl cobalamin defect? Methylmalonic acid. But 2 is both methylcobalamin and adenosyl defect. Now, what will accumulate in type 2? It is both methylcobalamin and adenosylcobalamin defect. What will accumulate in type 2? In type 1, only MMA. In type 2, what will accumulate apart from MMA? Along with MMA, homocysteine. So now tell me, homocysteine metabolism requires how many vitamins? Homocysteine metabolism requires how many vitamins? 2 or 3? 3. Tell me all the three. All the three: B6, B12, and folic acid. Don't mess up with your vitamins. Don't mess up where they are formed. This is only that isomerase is also known as mutase. Isomerase is a class, mutase is a subclass. So don't get confused. Now look at this. B12 is not just for MMA, methylmalonic metabolism. It is also for methionine synthesis. But there are two forms. Methylcobalamin is for methionine synthesis. Adenosylcobalamin is for what synthesis? So cobalamin has two forms. Methylcobalamin is for methionine synthesis. And adenosylcobalamin is for what synthesis? Adenosylcobalamin is for? Adenosyl is for which synthesis? I just asked you. Succinyl-CoA. But in B12 deficiency, both homocysteine and methylmalonic acid would be high. So draw them separate and then find out what is accumulating, what is depleting. Right? Now look at this. Sorry. Now they are saying that what is high here? Is there metabolic acidosis? Yes. But with metabolic acidosis, there are only two things you will be confused between A and D. Will both A and D lead to metabolic acidosis? Tell me. With both A and D lead to metabolic acidosis? A and D, because what is the primary presentation here? Metabolic acidosis. Will both A and D lead to metabolic acidosis? Both A and D? Yes. A will be metabolic acidosis due to propionic acid, and D will be metabolic acidosis due to methylmalonic acid. But can you distinguish? They have clearly told you methylmalonic acid. Acidosis because of methylmalonic acid. Now, can you choose the answer? Should be A or D? D. Isomerase is also known as mutase. So don't jump to one finding. One will be common. The other one will differentiate. Metabolic acidosis is common to both carboxylase and isomerase and mutase. What distinguishes? Methylmalonic acid. So keep doing that, please. The last question is homocysteine. Please draw them separate. They have different enzyme, different vitamin. But tell me, in B6 deficiency, what will happen to homocysteine, high or low? B6 deficiency, which is left side. Homocysteine will be high. But now, what will happen to methionine levels? If one is not working, will 2 be turned on? If one pathway is not working, will 2 be turned on? Yes. So here, what is distinguishing methionine? Methionine levels along with homocysteine will be high when there is one-step defect or two-step defect. Homocysteine and methionine levels will be high when there is one-step defect or two-step defect. If I'm saying high homocysteine, high methionine, 1. So keep them separate. Keep doing that. Folic acid and B12 both lead to megaloblastic anemia or macrocytic anemia. But folate trap is seen in B12 deficiency, not in folic acid deficiency. Know that. So what are the vitamins I asked you for homocysteine? B6, B12, and folic acid. Please bring them all together. What would be the primary history of homocysteine? Myocardial infarction, not arthritis, not pink iris. Okay, so that is why when you see myocardial infarction, and then what is high? Is homocysteine atherogenic? Yes. But with homocysteine, what else is high? What else is high in the question stem apart from methionine? So now you're confused between only D and E. So in which one of them both homocysteine as well as methionine we high? D or E? D or E? D. In E, what will happen to methionine levels? High or low? In E, low. So that's why you will pick D. So do differential. please pick up as this as the right answer, which is D, and this is your attendance. And I wish you good luck. Okay, we are done. I'm glad we finished on time. Please mark D